Colorectal cancer is the third most common malignancy globally. Because of its strict anatomical progression, treating it is a cornerstone of clinical surgery. Colorectal tumors emerge through a rigid, sequential life cycle. This life cycle unfolds across three distinct phases. It begins with specific intracellular genetic mutations, progresses into localized anatomical growth, and culminates in a problem requiring precise surgical geometry to solve. Mastering the management of this disease requires mapping that exact timeline. We have to trace the cancer from its microscopic pathophysiology directly to the clinical actions used to eradicate it. Understanding the physical pathway of the disease is the only way a surgeon can plan a truly curative oncologic resection. To find the starting point of the pathway, we must look past gross anatomy to the microscopic level of the colonic mucosa. Here, the disease is driven by the adenoma to carcinoma sequence. This is the molecular engine initiating the malignancy. First, an APC gene mutation causes epithelial cells to rapidly hyperproliferate. Next, a KRAS mutation drives these multiplying cells to form a protruding adenomatous polyp. Finally, the loss of the p53 gene makes the polyp break the boundary layer, becoming an invasive carcinoma. This precise sequence of mutations, APC to KRAS to the loss of p53, is the universal starting point for the vast majority of colorectal cancers. While the molecular engine is identical from patient to patient, the physical behavior of the tumor and the symptoms it produces are dictated entirely by where that mass lands in the colon. The large intestine is not a uniform pipe. Its physical dimensions and internal fluid states vary wildly from start to finish, and those variables dictate how a tumor will present clinically. Look at the proximal, or right side of the colon, which includes the cecum and descending colon. This section has a very large caliber, and the stool passing through it is still in a highly liquid state. In this cross-section of the spacious right colon, tumors tend to grow exophytically, expanding outward from the wall, without blocking the flowing liquid stool. These stealthy masses sit silently, shutting microscopic blood over time, presenting as severe iron deficiency anemia, rather than an obstructed bowel. Contrast this with the distal or left side of the colon. The descending and sigmoid colon have a much narrower lumen, and by the time stool reaches this point, it is semi-solid. In the narrow left colon, cancers form infiltrating annular strictures known as apple core lesions. The colon tries to force semi-solid stool through this rigid, constricted ring. This mechanical bottleneck causes alternating constipation and diarrhea, severe colicky pain, and early acute bowel obstruction. The patient's symptoms are essentially a physical readout. You are observing fluid dynamics and structural geometry interacting with the tumor mass. Finally, we reach the rectal environment. This is the terminal anatomy, tasked with handling completely solid stool just before evacuation. Low-lying masses in the rectum present with acute mechanical symptoms. Patients report tenesmus, a constant nagging feeling of needing to empty their bowels, and notice their stool taking on a narrow, pencil-thin caliber as it squeezes past the mass. Because the lesion sits in immediate proximity to the exit, rectal cancer also frequently presents with hematochezia, or bright red blood mixed with the stool. Regardless of whether the symptoms point to the right colon, left colon, or rectum, the gold standard diagnostic tool remains the same: a colonoscopy. Direct visualization allows the clinician to locate the mass, and precise metallic forceps are used to secure a tissue biopsy. Once the pathologist examines that tissue and confirms invasive carcinoma, the diagnosis is complete. The priority is now mapping the cancer's invisible spread. To map that spread, oncologists rely on the TNM system. It is the definitive framework for measuring the tumor's anatomical depth and distant reach. The T is tumor stage, measuring penetration depth. Invading the muscularis propria increases local spread risk. N is node stage. Cancer in regional lymph nodes means stage 3, mandating chemotherapy. M is metastasis, with distant spread typically targeting the liver and lungs. This table aligns AJCC stages 1 through 4 with clinical management. Stage 1 requires surgical resection alone. Stage 3 requires surgery plus chemotherapy. Stage 4 requires systemic palliative therapy, or surgery for resectable oligometastatic disease. TNM staging treats the disease as an expanding territory that must be systematically cleared. The core principle of curative colorectal surgery is strict. The surgeon must perform a wide anatomical resection of the affected bowel segment. Effective resection requires removing the corresponding vascular supply to capture the regional lymph node basin where microscopic disease often resides. To ensure the post-surgical staging is perfectly accurate, the pathologist must find and evaluate a minimum of 12 harvested lymph nodes within that resected tissue. This map displays precise targets. For a right hemicolectomy, high ligation of the ileocolic and right colic vessels is critical. For left-sided tumors, geography shifts to the inferior mesenteric artery. Ligating its left colic and sigmoid branches captures the entire distal lymphatic network. An oncologic colectomy achieves its therapeutic goal through a comprehensive lymphatic and vascular clearance. When the cancer is located in the rectum, the surgical approach requires an even higher level of precision. The absolute surgical standard here is the total mesorectal excision, or TME. Operating in the rectum is defined by extreme anatomical constraints. The surgeon navigates deep inside the narrow, rigid, and crowded bone structure of the human pelvis. The target is the mesorectum, the fatty lymphatic envelope completely surrounding the rectum. To prevent the cancer from returning, this entire envelope must be removed perfectly intact. This 3D cross-section illustrates the target surgical pathway. Surgeons aim for a microscopic avascular space located strictly between the visceral fascia of the mesorectum and the parietal fascia of the pelvis. This boundary is known in surgery as the holy plane. By utilizing sharp dissection directly along this avascular plane, the surgeon can extract the entire lymphatic envelope smoothly without breaching the tissue and spilling microscopic disease into the pelvic cavity. The oncologic benefit of this exact technique is massive. Adhering to the holy plane during a TME drastically reduces the local recurrence rates of rectal cancer. There is also a critical functional benefit. Staying strictly within this plane preserves the delicate pelvic autonomic nerves located just millimeters away, protecting the patient's urinary and sexual function and securing their long-term quality of life. Achieving a definitive cure in colorectal cancer requires flawless execution. It is the result of perfectly aligning a gross anatomical dissection with the microscopic margins of the disease's life cycle.